and I will try to cover majority aspects of the therapeutics, new medicines, including the old medicines, and before that I would like to cover some aspects of the heart failure as well. So, as it mentioned, what is heart failure? By definition, when there is a structural or functional cardiac disorder that is impairing the ability of ventricle to fill in or to eject the blood out of the heart, that is called the heart failure. In simple language, if I say, it is just that heart is failing to pump out of the blood. What is the epidemiology of this heart failure? So basically, I covered first with the CDC data that shows us the county-wise distribution of the heart diseases all across the US. So we are lying somewhere around here, so you can see that how much prevalence of heart diseases here in our Beaumont area, including the Texas and all the southern region. Also, yeah, it's quite high. Also, something interesting to find here, Australasia, that's Australia, that is having like 5.3% of the prevalence of heart failure. Followed by, it goes with the Germany here like 4%, then China 3.5%, Canada is 3.6%, and US ranges between 2.4 to 2.6%. So again, out of 100 people, nearly 3 people in the US are having heart failure. So it's a big thing. If we see all across the world, what is the epidemiology? So currently like 6.2 million patients are having a heart failure, and the way the trend is going, projected increase by 2030 is 45%. And 800,000 hospital admission occurred in 2016, and it reduced from the 2006 because couple of the medicines has been invented after that period. But still 2 million people every year visit having heart failure. And out of 1 million new cases every year, 50% having a mortality in just 1 year, 22 having mortality in 1 year, 50% having mortality in 5 years, 22% having 1 year, and 10% mortality in just 30 days. So it's a kind of a thing that we have to think about it a lot. And 40 billion cost has been spent for every heart failure patient every year, and it is projected by increase of $70 billion. So it's a huge amount. So how do you diagnose the heart failure? So from the symptoms, some on the examination, some through imaging, you can find out something. So that's the Framingham Criteria. It has major and minor criteria. If it includes one major criteria or one major and one minor, that will be giving us idea that this patient can have a heart failure. What are the major criteria? I took this slide from the up-to-date, so it shows that patient is complaining of nighttime dyspnea, or sometimes orthopnea is there. And when you examine, you can find that elevated JVP is there, pulmonary labs are there, third heart sound is there. On radiograph, chest radiograph, you will find cardiomegaly or pulmonary edema on chest radiograph. These are the major criteria. This gives us idea. And also patient will complain of bilateral leg edema, nocturnal cough, or hepatomegaly, pleural effusion. This gives us idea that patient can have heart failure. So what are the causes? So causes can be either with the valvular disease is there, or the causes is related to the lungs, pulmonary hypertension leading to right ventricular failure, or the pericardial disease like cardiac tamponade, or constrictive pericarditis, or obstructive lesion in the heart or great vessels like atrial myxoma. These can be the possible causes of the heart failure. And what the American College of Cardiology, American Heart Association give us idea of stages. Also the New York Heart Association made some classifications for this heart failure. So stage 1 includes that patients are having a high risk of having heart failure. What patients can be there? Like patient is having hypertension, diabetes, atherosclerosis. Those are prone to get having a heart failure in future. So this will be considered as a stage A. Stage B will be considered those patients who having a previous MI or LVH or other valvular disease. So those patients having a structural heart disease, though those patients doesn't have any symptoms of heart failure. When the symptoms of heart failure are there, it will be considered as a stage C. And then refractory heart failure means patient is not able to perform any activities, patient is requiring specialized intervention, those will be considered as a stage D. And along this side, there are New York Heart Association classification as well. So when patient doesn't have any limitation of their physical activity, it will be considered as a stage 1. But in stage 2, there is some less ordinary activities makes them some shortness of breath or symptoms will be there. In stage 3, they will become marked limitation of their physical activities. Even with the very minimal activity, they will feel the heart failure symptoms. They will be considered as a stage 3. And stage 4 will be they are not able to perform any activity. They are having symptoms even at the rest. So what is the classification? Generally, we see that less than 40 and 40 greater than above. But there is a mid-range heart failure as well. So less than 40, it will be heart failure with the reduced ejection fraction. Greater than 40, it will be the heart failure with preserved ejection fraction. But there is a mid-range as well, like 41 to 49. It will be considered as a mid-range heart failure. So what can be the causes? So main causes can be related to the cardiomyopathy. If it is a dilated cardiomyopathy or ischemic, it will be going more towards heart failure with the reduced ejection fraction. And when it is restrictive cardiomyopathy, hypertrophic cardiomyopathy, these patients can have heart failure with the preserved ejection fraction. I'm going to discuss in detail about the heart failure reduced ejection fraction a lot, but I'm covering with one slide with the heart failure with the preserved ejection fraction. So as just discussed, EF greater than 40, we will consider that as a heart failure with the preserved ejection fraction. And increasing age, female preponderance, diabetes, atrial fibrillation, this can be the risk factors, or ischemia, prior MI, left ventricular heart failure, restrictive or hypertrophic cardiomyopathy, this can be the etiology for that. In the echo, what will be the finding that will give you idea? It will be like decreased myocardial relaxation time or increased isovolumetric relaxation time. This will give us idea this patient is having possibly heart failure with the preserved ejection fraction. The treatment for this heart failure preserved ejection fraction is not very well established, except one thing I'm going to mention with the heart failure with the reduced ejection fraction. But basically, to reduce the overload, we use a diuresis, we control the blood pressure. Still, ACE and ARBs and the spironolactone, angiotensin receptor, neprilysin inhibitor, ARNI, and couple of other studies are going on for the heart failure with the preserved ejection fraction. But one more thing I'm going to mention with the HFrEF. So terminology for heart failure with the preserved ejection fraction usually called as a HFpEF, and heart failure with the reduced, it will be considered as a HFrEF. So what can be the heart failure with the reduced ejection fraction treatments? So everybody knows lifestyle modifications plays a major role for all the things. Then comes the medications, then comes the device or surgical procedures. So lifestyle modification, we know that smoking, alcohol, healthy diet, all these aspects will be beneficial for the patient, but heart failure medicines are playing vital role. But in case of refractory heart failure or after some criteria, patient can have support from some device or surgical procedures. I'm not going to go in detail about this in this lecture because other aspects will take time for heart failure reduced medicines only. So implantable ICD, CRT, left ventricular assist device, or surgical procedures like heart transplantation, PCI, coronary bypass, or valve replacement can be the option as a surgical, otherwise device related things. So what I have covered today. So American Heart Association gives us idea about this heart failure medicines in 2013. And then next update came in 2017 by the ACC, American College of Cardiology. The next update, even after that was not official publication, but the guidelines came in the 2019 and 2021. Recently they updated about more recent advances. So I have covered majority aspects of the medicines from this article, and I'm going to share it with all of you after this lecture. So basically whatever medicines we use, treatment is there, but what can be the target of those medicines? So we use ARNIs, ACE inhibitors, ARBs, aldosterone antagonists. Those all work on this renin-angiotensin-aldosterone system. Then beta blockers works on sympathetic nervous system. Then these neprilysin inhibitors called the ARNIs, they are working on natriuretic peptides. SGLT2 inhibitors, I'm going to tell more about it. Then hydralazine isosorbide dinitrate, that works on the balanced vasodilation through nitric oxide mechanism. Then beta blocker and new medicine ivabradine, that works on the decreasing the heart rate. Then one medicine soluble guanylate cyclase stimulators, it's called the vericiguat, that works on the guanylyl cyclase. Then for the relief of congestion, diuretics are there. Then ICD for the ventricular arrhythmia, CRT for the ventricular dysynchrony, then valvular replacement and aerobic exercise can be there. I'm going to discuss about a couple of medicines in a bit. So basically, when the guideline came in 2017, majority aspects for the first medicine was considered as the ACE inhibitors or ARBs. But in the 2019, it was very much proven that the ARNIs are the first line medicine we can start with. We do not have to wait for any other medicines to start before it. So ARNIs are kind of a thing that first of all we can start it. So the thing for ARNIs, I'm going to discuss in detail that for ARNIs, if we say, if the patient is already on ACE inhibitors or ARBs, then we should have 36 hours of washout period. We cannot start immediately. We should have 36 hours of washout period between them. And if patient is taking ACE inhibitors of like lisinopril or enalapril less than 10 milligram or valsartan of less than 160, then we can start with the 24 to 26. This ARNI is a secumetril valsartan combination. So secumetril will be 24 and valsartan will be 26. If patient is taking greater than 10 of enalapril or greater than 160 of valsartan, then we can start immediately with the 49 and 51. In a 2 weeks of follow-up time, we can increase up to 97 to 100 in twice daily. So now I'm going to, we have most of the time we have heard about the Entresto. That's a brand name. That's a medicine secumetril valsartan. So basically the indication for this treatment is HFrEF less than 40 or NYHA class 2 to 4. Or it can be administered with the guideline directed medical therapy as an add-on medicine in place of ARBs or ACE inhibitors. So I'm going to talk more about this mechanism of action of this medicine, because normal physiology of kidney is like that anytime any blood pressure is less or sympathetic activities are there or decreased sodium in the distal tubule. At that time, what will be the response to the kidney? It will be the renin production will be there, and it will be converted to the angiotensin 1 by the enzyme called the angiotensinogen, and then AT1 will be converted to angiotensin 2 by the ACE, angiotensin converting enzyme. And angiotensin, what does it do? So it has a propensity to product more vasoconstriction, more production of aldosterone, so sodium will be high, ECF volume will be high. So all these problems can be fatal for the heart failure patients. So what this ARNIs, secumetril and valsartan do? So this is a basic physiological mechanism for this. So valsartan, basically everybody knows, it blocks the angiotensin receptor blocker. It's an angiotensin receptor blocker. So it blocks the angiotensin 2 receptor type 1. When these receptors are majority present on vascular smooth muscle or the adrenal cortex where the zona glandula is located. So inhibition of this are going to cause somewhat vasodilation, otherwise it will restrict the vasoconstriction and decrease the ECF volume expansion. So it will be better for the heart failure patients. And what neprilysin do? So neprilysin is an enzyme. It basically inhibits the vasoactive peptides. Vasoactive peptides are responsible for the vasodilation. So we know about a couple of vasoactive peptides like natriuretic peptide, bradykinin, or adrenomethulin. So those peptides are inhibited by the neprilysin. So basically the vasoconstriction or less vasodilation will be there with the neprilysin. So when we inhibit neprilysin, the effect will be reduced. Means effect will be inverse. So basically vasodilation can be there, but why we do not use neprilysin alone? Why we are using valsartan? So basically thing is that if the neprilysin normally it reduces or it produces the breakdown of angiotensin 2. So when we inhibit neprilysin, this angiotensin will act up. So when we try to compensate this vasodilation with this one mechanism, but another mechanism will produce opposite effect. So to suppress that effect, we add the valsartan. So neprilysin inhibition with this valsartan inhibition, valsartan angiotensin 2 inhibition, they will act together to produce the effect, and it is more stronger effect than we use the neprilysin alone or ACE inhibitors or ERTs alone. So we have a couple of trials has been done for those things. So paradigm heart failure trial, it was published I think in 2014, and it covered like 84,000 people. You can see here like 84,000 people was covered in it, and they followed and then they found that in this study there is a comparison between the enalapril and this compounds. This is a compound name for this sacubitril valsartan and Entresto. So they compared between these two. So they found there was a death from the cardiovascular disease was like 20% reduction was there. For the hospitalization was like 21% of reduction was there. Or death from the any cause was like 16% less. So the mortality is also less, and heart failure hospitalization was also less. So as we discussed that there is a like 6 billion or 70 billion, 40 billion every year we have a heart failure burden on the government for this disease on the healthcare sector. With this medicine, this burden can be reduced. So paradigm heart failure was the first research project to prove us about this effectivity. And then the next project came and it showed us like pioneer heart failure. So it showed that when we use this sacubitril valsartan, there is a significant reduction in NT-proBNP. And everybody knows that NT-proBNP is a marker we use for the heart failure patients. So we can see just in 8 weeks of time, it's a baseline and it's 8 weeks of time, there is a significant reduction in NT-proBNP. So that was approved by pioneer heart failure trial. But the thing that the chances of having hypotension are there. So in the previous slide when I showed you this paradigm heart failure trial was basically more than for the outpatient population. But this pioneer heart failure was done for the inpatient. Then can we start this medicine when the patient is found out in a hospitalized? When they are hospitalized, can we start? So that's why this project was done, and then they found that it can be used in the hemodynamically unstable patient. So we will settle the patient first. Hemodynamically, once he is stable, then we will start to prevent that hypotension. That can be the possible side effect. Another publication came with the true heart failure. That was also done for this Entresto and other vericiguat, that's a cyclic guanosine monophosphate. So they found that after 12 months of study, because previous studies were for the short time, but now this was done for extensive time, and then they found that there is some increase in EF occurs after the 12 months of period. So 20 to 37% of EF is increased after starting of this medicine in a 1 year that was established. Also they found that reversal of cardiac remodeling. So basically it moves towards the that well-being of that heart, that reversal of cardiac remodeling is there. And then they also found that it can be started as a first medicine. We do not have to wait like we have other medicines like spironolactone, ACE inhibitors, ERTs. We know them more often, we use them more often. But this medicine can be started as the first medicine that was proven by this true heart failure. And So if there was one more study that was called the transition study, also provided the same benefits that before the discharge and even after discharge in an outpatient clinic we can start this medicine. It has proven benefits. But what can be the dose adjustments? Because we know now we can start, but practically in the patient population, how we should have to adjust this medicine. So as I discussed, as patient is taking enalapril of greater than 10 or valsartan of greater than 160, then we can start directly with the 49. If the patient is taking less than 10 or valsartan of less than 160, then we can start with the 24 to 26. Those are dose range, and we should monitor these patients when having a severe renal failure. We will not use them. And in the elderly population or the patient is having hepatic impairment, we will monitor them more. Let me tell you more about these things, that we will not use this patient is having any history of angioedema with the ACE inhibitors or ERDs, or the pregnant or lactate woman, and the severe hepatic impairment, child pube classification C. It is a classification basically consists of all the liver things like transaminase, INR, albumin, ascites or encephalopathy. So based on grading, we will not give this patient in severe hepatic failure or hypersensitivity. We will use, but we will cautiously use when there is a mild to moderate renal impairment like GFR of 30 to 60. But when there is a less than 30, we will monitor, we will start with the low dose, we will keep on monitoring every 2 weeks the renal things. Then only we can reach up to the target dose of 97 to 103. And for the child poop A classification, we will not bother much, but for B, we will monitor it more. With the even same, it goes with the renal artery stenosis or systolic blood pressure of less than 100 or volume depletion. Next compound is evaporating. So when we use this medicine, so basically this is used to prevent to decrease the heart rate. So when we have a maximum tolerated beta blocker, we are already using to control the heart rate, and even after that heart rates are not controlled, then we will focus on starting this evaporating. And you can start with the NYHA class 2 or class 3 heart failure as well. So basically evaporating, how will be the dose formation? So when there is a patient is of greater than 75, we will start with the 2.5 twice, and we will monitor in 2 to 4 weeks. When there is a less than 75, we will start with the 5 milligram BID, and we will again monitor in 2 to 4 weeks. We have to monitor that the heart rate should be between 50 to 60. If it is less than 50, we have to reduce the dose because we are giving too much dose. If it is greater than 60, we have to increase the dose because but the maximum is the 75. We cannot go beyond that. So we will start with 2.5, 5 is the standard, we can increase up to 7.5. Same thing applies in the same slide, but with the conduction defect we will again monitor because we will start with the 2.5 and monitor. Again, contraindication and caution for these patients again. We will never use this medicine in HFpEF, only HFrEF. Hypersensitivity, child poop classification C, we will not use. We will not use in acute decompensated heart failure. Neither we will use in any sinoatrial block or second degree heart block or persistent AF. Next compound is sodium glucose co-transporter inhibitors. This medicine is kind of a blessing, and there are many research going on this medicine right now, because basically this medicine was discovered to treat the diabetes, and now the research are proving that it can be used without the diabetes patients as well, because it has a significant improvement effect on heart failure patients. So basically I have included two medicines. Those are most commonly used. Dapagliflozin and Forxiga is the brand name. Empagliflozin, that's a Jardiance, is the brand name. So it can be started when the patient is having heart failure of less than 40, EF of less than 40 with or without diabetes. Or classification NYHA of 2 or 4, it can be added on other medicines. So we can start these medicines. And then comes what can be the mechanism. So mechanism of action of this medicine is still not clear. But there are some hypotheses because this is very effective. So there are some hypotheses came up that what can be the thing for this, because SGLT2 inhibitors have some osmotic diuretic effect without the electrolyte abnormalities and RAS activation. So this is a big thing. Also anti-inflammatory, anti-fibrotic, or improvement in myocardial energetics by increasing the hematocrit and oxygen delivery. Those are the things that attracts people that we should start this medicine. And there was one study called the DAPA heart failure study. It was done on around 4,700 patients and for over 18 to 24 months. And the same thing, then inclusion of EF of less than 40 was there, and anti-pro-BNP was greater than 600. Those patients, basically the heart failure real patients, that they were included. And they found over the period of 18 to 24 months that very significant, like 30% decrease in hospitalization. We can see the death from the cardiovascular cause were also 80% less, or the death from any cause was like 17% less with this compound. And it was studied extensively for about 2 years, and then this was results. And this is very latest finding because recently, means like 5 days back, this research has been published. This is by the European Society of Cardiology Congress. It's like a AHA and ACC meet we have every year in United States. European Society is also a big thing. So they also made a conclusion that this medicine can be used for both. As I mentioned in my previous slide, that I'm going to discuss about this one thing in the HFpEF treatment. So this medicine is used for the HFrEF as well as HFpEF. So this is a new medicine, and this study was eye-opener for everyone because we do not have any significant medicines for the HFpEF. But this medicine was proven that reduction of heart failure hospitalization for both the patient side, either HFrEF or HFpEF, like 30%. The only problem with the HFpEF thing is that this medicine is responsible for the decrease in renal decline. Means progression of worsening of kidney will be hold when they are used in HFrEF, but not in the HFpEF. That was the only thing. Only thing that we didn't like about using this in HFpEF, but still they have cardiologists have started using it based on this study. And this study actually started very beginningly, but now it has been proven. So same thing is that with the HFpEF we can use, but progression of worsening of the kidney will be less effective as compared to the placebo in case of this use. Otherwise, for HFrEF and HFpEF, both things we can use this medicine. Also, a couple of other trials have been done, like soloist trial that was for the sotagliflozin. It was showing the same thing, like decreasing cardiovascular death or heart failure hospitalization, urgent visit were less. So again, when we want to start this medicine, I'm going to talk about its dose just in a little bit, but what can be the cautions or contraindication we have to pay attention for this medicine. So this medicine we will not use in case of type 1 diabetics or any having hypersensitivity or lactation, because we do not have data, and we will not use in the patient who is having on dialysis. And we will pay attention for the GFR when there is a less than 30 in case of dapagliflozin or less than 20 in case of empagliflozin. We will use it cautiously. Same thing that mycotic genital infection can be there because the mechanism of this medicine also acts on the kidney. It prevents the reabsorption of glucose into the kidney. So more glucose will be flushed out. So it is good for the fungal infection. We will not use this in case of ketoacidosis patients or sepsis into urinary tract or pyelonephritis or necrotizing fasciitis. Those will be the things. So till now what we have discussed, I would just like to summarize in a bit that the sacubitril valsartan, SGL2 are confirmed for the treatment for the HFrEF, and combination of this either Entresto or ASAR, because we will not use both of them together, like Entresto and ACE inhibitors and AR, we will not use them, either of them, because as I mentioned, in couple of patients we cannot use this Entresto. So either the combination of these or along with beta blockers, spironolactone, eplerenone, mineralocorticoid receptor antagonist, SGL2 inhibitors, they have synergistic effect. So this, when they are used, it is a complex things, of course, before the patients as well, but I am going to discuss that in a bit. So what will be the doses? So we know most of the medicines because we are using them daily. But there is a board question as well, and a couple of other things are like that bisoprolol. We do not see often, but we can start with the 1.25 milligram and we can increase to target dose can be 10 milligram. Other medicines we are much familiar with, as I just discussed about the Entresto 24, and the dose can be there. Then herbs, we know that losartan 20/50 and can reach up to the 150, valsartan same 40, 160. Candesartan we less often use, but 4 to 8 milligram daily, and we can move up to 32 milligram. Same things goes with the eplerenone and spironolactone. We can start with like 12.5, 25. We can increase up to 50. For SG2L2 inhibitors, we will start and the target is the same, 10 milligram for the both medicines. Vasodilators, we know evabrine, I just discussed, we can start with the 2.5, increase up to 7.5. Now comes the new medicines. These are the medicines, one of the medicine, Vericiguat, were recently approved by the FDA. So we will not see this medicine often with the patients we are having here, but in the coming years we will see those medicines, Vericiguat and omecamtiv mecarbil. So Vericiguat is basically it modulates the nitric oxide. It works on the guanylyl monophosphate diesterase pathways to basically works on nitric oxide generation to vasodilate. So Victoria heart failure was the biggest trial, was recently published, and it shows that we can start with the 2.5 milligram, we can titrate it up to the 10 milligram once daily, and it reduces the heart failure hospitalization. This medicine and along with another medicine I am going to discuss, it doesn't have any survival benefit. But when there will be a less heart failure hospitalization, patient will have an improved quality of life. Then another trial was done, galactic heart failure, that was done for the omecamtiv mecarbil. This is basically a myotrope that activates the cardiac myosin to pump up the blood more. But the good thing about is this, it will not consume much oxygen. So without consumption of oxygen, when the heart will push more cardiac output will be there. So this is a beautiful thing. So cosmic heart failure trial was done for this study as well, and it showed that the patient can be started with the 25 to 50 milligram BID, and it had improvement in reduction of left ventricular ejection, systolic and diastolic, and pro-BNP reduction was also observed. Same thing was proved by the another trial, galactic heart failure. So basically, these medicines, as I mentioned, they are not capable of modifying the survival, but they have significant effect on heart failure, recurrent admissions. And then next compound is iron deficiency correction, ferric carboxymaltose. Many people can have a question that can't we use that iron, ferrous sulfate, ferrous gluconate, iron sucrose we use for the patients here in the hospital. But the study has proved that these medicines are not effective as compared to these medicines like ferric carboxymaltase, because it has a capacity of having a more production of hematopoietic impairment, and mitochondrial ATP production has been hampered with the iron deficiency. Negative influence will be there with the myocardial and skeletal function. That can be prevented with this ferric carboxymaltase. So meta-analysis proved that there is a reduction in hospitalized. And the beautiful thing about this medicine is just we give only 2 days. Just when we see that ferritin is less than 100 or even less than 300, and the transferrin saturation is less than 20% and EF is 50%, less than 50, we can give either like a 500 milligram or 1000 milligram, and one dose can be given before the discharge in the hospital, and another dose can be given 6 weeks later. So both the dose will be given as an IV. So these are a couple of the trials I just mentioned, like this is heart FID and fair heart failure. These are for the IV peroxycarboxy maltase. These are the trials running right now. This was the Victoria trial I just mentioned for the vericiguat that works on the one-leg cyclist stimulators. Galactic heart failure for that omecamtiv mecarbil. This has recently been published, Emperor Reviews, and these are the DEPA heart failure, paradigm heart failure for Army SE-L2 meters. So this is another slide showing us idea that there are a couple of more trials are going on for same medicines. Like if I see for the sacubitril valsartan, we discuss about Pioneer have Pro heart failure, but therefore heart failure preserve ejection fraction. One more trial is going on that called the Paragon heart failure. Same thing when we discuss like soloist for the sotagliflozin, galactic heart failure for the omecamtiv. Couple of medicines we do not have much idea, but the trials are going on. Like if we see ATT, TR8 here, so Tadava, tafamidis and mavacamten, those are the new medicines. We do not have much information about those medicines, but we will see these medicines in coming years. So as an internist, as an internal medicine physician, what will be the message from this lecture? That we can start the interest of medicine. But when we see this thing, then we can refer this patient to the cardiologist. I need help. When patient requires IV ionotropy with the current medicines, or the heart failure 3B or 4 stages there, end organ dysfunction, EF was less than 35 with the current medicines. Defibrillatory stage, but defibrillatory shocks are more there than hospitalization more than one time. Edema despite escalating the diuretics, low blood pressure, high heart rate, even with the medicines we are giving. Or when we see that improvement is there, so to down titrate also this medicine, we will refer this patient to the cardiologist. Now comes like same thing is applicable for the here. Now comes the thing that what can be the reason for the non-adherence for these things. As I discussed couple of medicines, it is complex for even for the physician and nurse to understand about these things. So what can be the things that can be the responsible for this non-adherence? Majority of the time, patient doesn't understand about all this medicine because of they are either poor health literacy is there, or sometimes they are depressed, or their cognition is not good, vision is not good, they are socially isolated, or the polypharmacy is there, out of pocket cost is also there, that is also big issue, lack of social support to help with them, or homeless, they are homeless. These can be the factors for the non-adherence. So we can focus on these aspects when we see these patients here. And what can be the steps we can take to improve this thing, that they can have more understanding. So we can educate more when they are hospitalized here. We can personally go and explain them. We can hand them more printed materials, that education materials, that this medicine is for this purpose. We can educate them about the side effects as well, because sometimes side effects will be there and they will be afraid that what is going on and they can stop. We can consider the factor to lower the cost. So we can prescribe the generic medicines, and we can involve the pharmacist, social worker, case manager for that as well. And we can help with the health aids as well, all the tool box to fill in once a week, or alarms for that each time when they have to take the medicines. So we should educate them for the like motivational interviewing, that we should educate them that this is going to make your life better if you use it adequately on proper time with the proper doses. So this education and all these aspects, we have to include nurses, case managers, social workers, pharmacists, to include that better understanding will be there, cost will be less, so we can include more than. But now the thing is that specific cohorts for this heart failure care. So Afro-American people, for these people, we generally do not use, it is very risky to use these ARNIs, ACE inhibitors, ARBs. So we will think about them before we start. We have to monitor them very cautiously. Also, in case of older age, like more than 75, we should consider about the potential risk of fall, polypharmacy will be there, worsening of renal function. Those will be more with the same medicine as compared to the young people. And there are the things all I mentioned to reduce the cost of this care, because all this medicine I discussed, they are expensive, but they are effective. So what can we do from our side? So as we mentioned that we can coordinate with the care. Sometimes what happens in a clinic, we are ordering the same labs and patient goes to the specialist and they are ordering the same labs. So duplication can be reduced to unnecessary duplication of the charging. Also we can prescribe the generic medicines. We can take support of all these other associated staff with working with us. We can do the price matching for these patients. Practically, this is not possible for physicians to do all these aspects, but we can include our paramedical staff with these things. As I mentioned of this slide, again I'm mentioning that after covering all these medicines, same thing I'm going to cover, that ARNIs, ACE inhibitors, ARBs or aldosterone antagonist all works on renin-angiotensin aldosterone system. Beta blockers work on sympathetic nervous system. Neprilysin inhibitors, ARNIs work on natriuretic and vasodilatory peptides. SGLT2 inhibitors we just discussed. Hydralazine isosorbide dinitrate on vasodilation. Beta blocker evaporating for the decreasing heart rate. Then vericiguat, guanylyl cyclase stimulator for they work on the guanylyl cyclase. Diuretics we know, ICDs, CRTs, surgical interventions we discussed. So of all medicines I discussed, these are all the medicines basically covered here. Some medicines they have survival benefit, but some are just reducing the heart failure hospitalization. So we should focus that beta blockers, mineralocorticoid antagonists, ARNIs, ACE inhibitors, ARBs, SGLT2 inhibitors, all these have survival benefits. These all medicines, new medicines we just discussed, and these digitales, diuretics, these are just basically reducing the heart failure hospitalization, but it is again a big thing because it will have less financial burden on the healthcare sector. So out of all medicines, basically we should focus that heart failure patients should be on basically on these 5 medicines. Basically, it will be renin-angiotensin inhibition through ACE inhibitors or ERT, or we can use the neprilysin inhibition, ARNIs. We can work on the sympathetic nervous stimulation beta blocker, or aldosterone inhibition, or SGLT2 inhibition. Those 5 medicines are core medicines, and as I mentioned that apart from everything, this basically for us, we do not end up having these things. We should focus on our lifestyle modification. As a resident, we are stressful once we become a physician. Many of people here, I know that they are very much active with the sports, but try to improve more sports. Yeah. These are the messages given by the Olympics recently. So you are never too young or never too old to chase your dream. That's it. That's it from my side. Thank you. And, I would like